Thank you, Sages, and thank you to Dr. Morrow, Dr. Campbell, for the opportunity to speak. I'm speaking on mitigating unconscious bias, so natural flow behind Dana's talk. So why do we need to mitigate? Unconscious bias has been shown to lead to microaggressions and even macroaggressions, and these have a significant impact on the recipient of those microaggressions. They also have an impact on those who surround and who see these microaggressions, and it has an impact on patient outcomes. And so we're here to give the best patient care that we can. So the impact of unconscious bias is pervasive. Regular exposure to perceived discrimination has been shown to adversely affect not just the physical health, but also the psychological health of the recipient. It's been linked to depression, anxiety, and trauma responses. Racial and ethnic discrimination is an identifiable stressor. It is actually, racism is now a public health risk. And it plays a role in health disparities. It is associated with hypertension within the Black and Native American populations. And importantly, too, for us, as we are trying to diversify our workforce, it impacts the fragile pipeline of women and minority physicians in medicine and academia. This is too much for us to talk about, but I wanted to put this slide up to look at the gender equity pipeline. So just one area. And the many, many places that we lose folks in this pipeline, from those that are entering the pipeline who have concerns on work-life balance, cultural context, do they see themselves represented? Then within the pipeline, do they have clear expectations and perceptions? Do they have a lack of work-life balance at this time? Do they have a lack of reward for the hard work that they've put in? And then when leading the pipeline, do you have access to mentors and sponsors to help you develop into the leader that you need to be to help to continue this work? And then when we talk about our patients, this is really, really important too, because implicit bias during diagnosis has many, many, many implications. It has a negative impact on physician-patient interactions. It affects that trust between the physician and the patient. It can also change treatment plans. And while that sounds shocking, it is indeed true. So recent studies have shown that minority patients are offered minimally invasive surgery less often than non-minority patients, and that breast cancer patients who are minority may not be offered breast-conserving therapy because they may be thought that they will not continue with the rest of the therapy. And then that tends to perpetuate existing disparities within the healthcare system. Diversity in the healthcare workforce is important. Representation is important, but it also affects patient outcomes. So studies have shown a 50% reduction in infant mortality for African American babies when there is a concordance between the physician and the patient. So what are we going to do? We can't outlaw bias. We can't walk in and say, no bias here today. So how do we put in strategies to make a change? We've tried many things. We've tried diversity training, but as you know, unless it's coming from a place of voluntary participation, it may just end up being window dressing. Grievance procedures and hiring tests and performance ratings may actually worsen bias. It has been shown that women and minorities are rated lower on performance ratings. So we need a multidimensional approach. We can't just be the sole savior. We need everybody on board. So this is the individual as well as the organization putting forth a commitment to mitigate this bias. There are multiple strategies to do so. These involve the organization, the individual, and both together. So we need the leadership to demonstrate commitment, that this is not just lip service, but something that the leadership is deeply invested in, that they want to see the culture of the organization change, to be more involved in inclusivity, more accepting, and build that institutional capacity for change. I won't talk much about allyship, but allyship is important. And very small things can make a big difference. So your impact really does make a difference. Culture change is hard, mindset change is hard, And we've seen this with even simple things in our ordinary life. So imagine something like changing biases that you may not even know that you have. So that takes a shared desire for change. It takes assessment of the institutional culture. When you walk the halls, who do you see on the halls? Does it look inviting to someone that may think of applying to your institution? We need an improved capacity for diversity, equity, and inclusion within the institution. We need to be prepared to remove exclusionary environments, so environments that perpetuate implicit and explicit biases. And this means taking a really close look at what the culture is in your institution. Do you find that certain residents and certain students are not invited to certain events, that they're not promoted, that they're not sponsored? We do know that there's a higher rate of adverse actions for minority residents, and we also know that non-white faculty have a lower promotion rate than white faculty. If you haven't, take the implicit association test. It is surprising, and it will open your eyes to your own biases that you may not be aware of. It did for me. So how do we mitigate bias in admissions, hiring, and promotion? We need to be deliberate. We need to have a framework. We need to have a strategy. So this was proposed by Dr. Capers, that you require the use of the implicit association test prior to application review and interviews, that you use a standardized questioning for interviews. You'd be surprised at how much variance there is in questioning someone for interviews. And that might put in some bias into your thoughts as to whether this is a good candidate for your institution or not. Improve the diversity of your admissions and promotions committees. That has been shown to decrease the bias that is promoted. Dr. Capers' study showed that when they used the implicit association test in a comprehensive manner in a seminar prior to the admissions committee members performing their duties, 2/3 of them felt that the IAT was valuable in reducing bias. About 50% of them were cognizant of their results while interviewing, and 21% reported that knowledge of their biases affected their decisions. So it made a difference. So use of this is important. And then addressing our personal biases. So we all have biases, and taking that test will help to show which ones you do have. But though we have biases, we have to be able to function in a way that is aware of the biases that we have and how those biases tend to affect our decisions. We need to be systematic in our approach, use concrete guidelines like structured, standardized questions for interviewing, and then be open to new experiences, listen to others, develop a more diverse collegial network. Take some time to reflect. So prior to doing important activities like interviewing for residency positions or interviewing medical students, writing letters of recommendation, think about your biases and make sure that you take into account whether that may play a role in the way you write that letter of recommendation. Are you going to write that letter of recommendation for a female student using very flowery language that's not as strong as you would write for a male student, saying that student shows initiative and drive? Rather, the female student, you say, is warm, has good bedside manner. It's not as strong a letter of recommendation. Then question and actively counter your stereotypes. And to do that, you have to acknowledge your biases, and then you have to actively reject the stereotype, acknowledge discomfort, and be direct. I love the cultural competency and moving that to cultural humility, which means moving it to a point where you ask questions, that you're open, that you take criticism and feedback and use that to improve. Hidden curriculums. There's so much that we learn that is not in the textbooks. That is the way my attending finesses this part of the procedure. That is the interaction between two faculty members, or the interaction between a faculty member and their patient. Are you making sure that everyone has access to this additional knowledge, or are certain people excluded? So taking advantage of making sure that everybody has access to these hidden curriculums is important. Then diversify experiences. So make sure that you diversify the folks that you have in your circle. That has a positive impact on decreasing unconscious biases, increasing representation in institutions, and also organizations, forming collaborations with organizations that do cater to underrepresented minorities. Strategic directed contact, engagement, mentoring, contact and exposure, and accountability. So engaging with our folks very early. Pathway programs are very important here. College recruitment programs. Ensuring that folks see themselves represented in the field. Mentoring them. Improving the visibility of representative organizations, which I'll talk about here in a second. Increasing those collaborations. And then formulating guidelines is very important. So pathway programs have been shown to increase folks entering the pipeline, and contact and exposure with visibility of these representative organizations is really key to that. So coming to an organization and seeing yourself represented. I remember the first time I saw the first black female surgeon in my life, and it makes a difference. Increasing representation. Dr. Telem mentioned about African American female chairs. We now have 3, and they all happened in the last 7 months. Yeah, it's amazing, but we went from 0 to 3. But representation matters. So after we had 1, quickly there were 2 more, so very good. But if you look at this chart of department chairs, 89% of them are male. We have only 10% female department chairs here in the United States. And then I mentioned mentoring. It engages your leadership. It helps them to think about their own biases and reduce their own biases. Formal mentoring programs are also very important. I have this picture here of Coca-Cola because Coca-Cola did this. Now, they did this in reaction to a lawsuit for $193 million, but they did put in a strong mentoring program. And a few years later, they had 17 African American women who were vice presidents or higher. So it does matter. So what can we do as SAGEs? How do we mitigate unconscious bias? Incorporate measurable, evidence-based reduction strategies into our training programs and membership. We need to enhance our mentorship programs for leadership. Give that footing that people need. Incorporate cultural competency and humility into that leadership development, and enhance our collaborations with our representative organizations. Thank you for the opportunity.